Good morning. Today we will be talking about puerperal pyrexia. Now, puerperal pyrexia is a common medical condition, and it's an important differential diagnosis that as an obstetrician you must be able to put forth when faced with this clinical scenario. Now, the temperature must be 38 degrees or higher and should be on 2 different days in the first 10 days postpartum, and you have to exclude the first 24 hours, of course. The temperature must be taken by a standard mean. You take it by thermometer, by mouth, and it has to be the same technique, and you have to do it at least 4 times per day. Now, many things can cause puerperal pyrexia. Now, puerperal sepsis being the most serious of them, breast infection can cause it as well. Other things such as urinary tract infection, respiratory system infections as bronchopneumonia, bronchitis, thrombophlebitis is also a condition that may cause it, and other general conditions such as maybe any sort of fever, typhoid, malaria, flu, or whatever. This is a simple diagram that that will help you remember things that can cause puerperal pyrexia. As we can see, lung infection, mastitis or breast engorgement or breast infection, urinary tract infection, and the uterine cause, of course, which will give us puerperal sepsis. And anything that can cause deep vein thrombosis and pelvic thrombophlebitis. Now, it's always advisable to consider any case of puerperal pyrexia or elevated temperature during puerperium to be puerperal sepsis until you prove it otherwise, as this is a serious infection that can occur in the puerperal time, and along with preeclampsia and obstetric hemorrhage had formed the most lethal 3 causes for maternal death along the last decades here in Egypt. Now, puerperal sepsis is defined as a wound infection that occurs in the genital tract, being the vagina, the cervix, or the uterus. This happens during labor or during the first 3 weeks after labor. Now, we'll be discussing the etiology of puerperal sepsis. Now, this will include the predisposing factors, the source of infection, and the causative organism. Now, predisposing factors, there are some general factors and local factors. General factors are due to decreased immunity, things such as anemia in cases of repeated hemorrhage during the antenatal period. Some patient maybe with a placenta previa or recurrent hemorrhage that will cause a drop of hemoglobin. Maybe a case of postpartum hemorrhage. If during labor postpartum hemorrhage occurs, there's a drop of hemoglobin. General causes like diabetes, and a septic focus. The patient might have an infection already somewhere else in her body, maybe active tonsillitis or a respiratory tract infection. Now, cases where there's local predisposing factors, which means it's a factor that occurred during labor in the genital tract. Maybe lack of antiseptic measures, maybe the doctor or the nurse was not properly scrubbed in, or the tools they've used are not properly sterilized. Cases where there is a premature rupture of membranes, and now prolonged rupture of membranes more than 24 hours definitely predisposes to infection. Prolonged labor and excessive vaginal examinations where there was repeated examination by different doctors and different nurses, this can also lead to infection. Retained parts of the placenta or membranes. If you deliver a patient and you forget some of the placenta, you forget to inspect the placenta after you've delivered your case, or there's some membranes left over inside the uterus. Now, this is some tissue that will become necrotic, and in the presence of organisms such as anaerobic organisms, it will start to rot and will predispose to, of course, puerperal sepsis. Now, intrauterine manipulations during labor, maybe you have a retained second twin, or you need to do an internal podalic version, maybe manual separation of the placenta. Now, introducing many hands or different people. I mean, if there's a junior resident that's delivering a patient, and then he's having some trouble or a retained placenta, or he needs to do a maneuver, and he calls in a more senior doctor to help him. Now, maybe more than one patient introducing their hands inside the field will also predispose to infection. things like instrumental delivery, because it usually predisposes to genital tract lacerations. Of course, any laceration or any infection could be potentially infected, as usually labor itself is not a completely aseptic setting. I mean, sometimes during labor, the patient, when bearing down, stools will come out, so you can have these lacerations actually contaminated or infected. Now, circularized sutures have always been there's always been a query about them, as they are made of material, or whether it's polybraided or not, depending on the suture used. Sometimes the microorganisms stick to these sutures and might sometimes predispose to infection, as they are present in the genital tract for a long time. Now, the source of infection can either be from outside the body or inside the body. Exogenous, which means it's completely from outside. Usually it's people who are attending the labor, the doctor, the nurse. Can be a droplet infection, or the equipment itself has not been properly sterilized. An endogenous source, it means that organism was already present in the genital tract during delivery, whether it's an active infection or not. An autogenous infection is usually it's an organism, it reaches the genital tract from another place in the body, maybe via the bloodstream, like I said, maybe a tonsillitis, some sort of respiratory tract infection, bronchopneumonia, bronchitis, or even some cases from caries teeth, have some infection from the mouth. The causative organisms in cases of puerperal sepsis may be anaerobic. Yes, okay, they are the most important organism. They are usually non-pathogenic, but let's say in the presence of dead tissues, something like retained placental parts or maybe even membranes, they become very pathogenic, but they usually cause a mild infection. Nothing compared to group A hemolytic streptococci, as they cause a really severe infection, which can be life-threatening. Of course, there are other organisms, as puerperal sepsis is a broad spectrum of microorganisms that can cause this condition. You have staphylococci, E. coli, non-hemolytic streptococci, things like Pseudomonas and Clostridium welchi, which are very rare but cause a serious condition which can cause uterine gangrene. Now, the pathological picture of puerperal sepsis depends on the site of infection and its spread. So if you consider the primary site of infection, commonly it's the uterus. You also have infected lacerations, lacerations in the perineum, vagina, or the cervix during labor, whether that be during instrumental delivery or other techniques that had led to these lacerations during delivery. Now, they usually appear as ulcers with a very dirty base and a greenish yellowish discharge, and usually the laceration is surrounded by edema. You have secondary sites of infection, which are usually due to local spread from the primary site, which is the uterus or the infected laceration. Most commonly, we're talking about parametritis, or spread to the parametrium, which causes a condition called pelvic cellulitis. Now, the infection usually reaches the parametrium usually via the lymphatic spread, or directly from the cervical or the vaginal tears. It's usually unilateral, coinciding with the site of the tear or the laceration. It might make a mass of exudation that pushes the uterus to the opposite side. Usually it's a lot of fluid that's filled with cellular infiltrate, which accumulates in the broad ligament. Now, if an abscess is formed, it usually points maybe above the inguinal ligament, or it may point downwards in the vagina or rectum. Sometimes it pushes upwards in the perirenal space, or it may push backwards to the gluteal region, forming a gluteal abscess. Now, if that abscess actually heals, it heals by fibrosis and pulls the uterus towards that side. Salpingitis is another form of local spread in cases with puerperal sepsis. Now, it happens due to lymphatic or vascular spread from the primary site, which may be the uterus or the cervix itself. The tube becomes inflated and accumulates exudate. Sometimes that exudate turns into pus, so you end up with a hydrosalpinx or a pyosalpinx. If the ovary is involved, you get an ovarian abscess. Sometimes they are all entangled in a tubo-ovarian complex or a tubo-ovarian abscess, which is a serious condition that needs immediate care. Now you have pelvic thrombophlebitis, where there is thrombosis and infection in the veins of the pelvis. It usually comes secondary, or spread comes from the parametrium itself or the uterine wall veins, which have thrombophlebitis in them. Now this spreads to other pelvic veins, and it may include the inferior vena cava or the femoral vein. Now the affected veins usually become either partially or completely occluded, and in very serious conditions, these veins, the thrombosis in the veins, give off septic emboli that might spread to everywhere else, giving us the general form of infection, which we'll deal with later. Now, peritonitis occurs as another form of local spread, where the infection spreads to the peritoneum itself. Now, it can be localized in the form of a pelvic abscess, or it can actually become generalized in cases where there is a poor general condition of the patient. Infection reaches the peritoneum usually through the lymphatics of the uterine wall, or maybe pus or exudate from that had accumulated inside the tube, the fallopian tube, and sometimes drips into the peritoneum, giving us that condition. It can also come from the direct spread from the cervical and the vaginal vault lacerations. And now in the localized type, the effusion usually collects in the Douglas pouch or the cul-de-sac. They're usually covered by the omentum, the intestine, and the colon. Everything rushes in to contain the condition, giving us tender cystic swelling that can be palpated vaginally, and you can feel it behind the uterus. It's a very painful condition, and the patient is usually very feverish, and it's very painful. Now, the generalized spread in cases of puerperal sepsis gives rise to septicemia and septic shock, which is a very, very serious condition, as I said before, especially in cases with low patient resistance and low immunity, and patients with poor general condition. It gives rise to severe infection, especially when infected emboli travel in blood, giving us that clinical picture. The clinical picture of puerperal sepsis depends on the pathological type and the site of infection itself. If we're talking about an infected laceration, now you can actually see the vulva or the vagina, wherever the laceration is. There will be local pain. The patient will be feverish. The wound itself would be hot, painful, red, swollen, sometimes covered with purulent exudate. Sometimes it might appear as an ulcer with a grayish or a dirty base with a green or yellowish discharge. The uterus itself usually is bigger than its normal size. It probably has retained products in it. Usually it's very tender, so if you touch the patient's abdomen, the patient actually might jump up because it's very painful. There will always be a foul smelling discharge coming from the vagina, as these rotting products of conception inside, and you'll have the discharge coming outside flowing from the vagina, so you'll smell it. Will be very, very bad smell. You can actually tell where the patient has puerperal sepsis by just being around the bed. You can smell. It's a very, very bad and distinctive smell. Parametritis, it happens or starts usually 7 to 10 days after the delivery. It's usually spread from a cervical tear or a high vaginal tear in the vagina. It's usually unilateral. It depends on the side where the tear is. It usually coincides with it. The exudate accumulates on one side. It causes a tender mass in the fornix. You can actually be palpated, usually to the right or to the left, and it usually pushes the uterus to the opposite side. The fever is usually very mild, and the tachycardia itself is not that much. And there's always a deep-seated pelvic pain with the presentation. Now, abscess actually forms, and this points usually above the inguinal ligament, or the spread goes towards the vagina, rectum, or the bladder, where it points and might actually rupture in there. Salpingitis, which gives you a similar clinical picture to pelvic inflammatory disease, PID. It occurs 7 to 10 days post-delivery. The pain is usually bilateral. Depends, as the organism usually affects both tubes at the same time, and might cause a tubo-ovarian abscess or a tubo-ovarian complex on both sides. The adnexia are both usually very tender, and there's a lot of pain on moving the cervix. Pelvic thrombophlebitis presents usually on the second week after delivery. There's a lot of pain in the pelvis. There's a low-grade fever, but the pulse is inconsistent with the degree of fever. The thrombus might extend up to the femoral vein, and then the lower limb becomes very edematous and white. It's usually not tender. If the thrombosis extends up to the inferior vena cava, then both lower limbs will be very edematous. Peritonitis, which is a serious condition, which is the ultimate local spread of the disease. The organism or the infection spreads to the peritoneal cavity. There's exudation, and the peritoneal cavity is filled. There's fever, there's abdominal pain, there's tenderness. The patient's general condition usually deteriorates very fast when the spread reaches to peritonitis. It's usually reserved, like we said before, in patients with poor general condition, usually predisposing conditions such as diabetes, anemia, and the patient then might develop septicemia and septic shock. Now, septicemia, which is one of the most serious complications along with septic shock, it occurs usually within the first week after delivery. The fever is usually very high. Tachycardia is also very high. Patient experiences rigors. It's usually associated with symptoms of general peritonitis. So we're talking about tenderness, rebound tenderness. And the patient usually the condition deteriorates very fast, and if it's not properly treated, we then develop into septic shock. We go into the hot phase, and then the cold phase, and then the irreversible shock or death. So when it comes to diagnosing puerperal sepsis, we go for history. We ask about pre-existing infection in the genital tract. Patient who was pregnant and had history of recurrent vaginal infection with purulent looking discharge with foul smell in the vagina. Other like more general conditions and diseases such as diabetes or anemia. We ask about the mode of delivery. How did this patient deliver? Now, was it a cesarean section? Was it a vaginal delivery? Was there instrumentation used? Was there a premature rupture of membranes? What was the duration of that rupture of membranes? And where was the place of delivery? What did that patient deliver in a private hospital? Or did she deliver at home? All these can help us point to puerperal sepsis. Okay, now while examining the patient to exclude puerperal sepsis, we have to assess the extent of the disease itself. We have to exclude other causes of puerperal pyrexia. Like we said before, it could be a case of simple breast engorgement or maybe mastitis. We have to discover the source of the infection. If it was outside the GITs, we have to examine the vital signs, the pulse, the temperature, the blood pressure, the respiratory rate. We have to take a look at the tonsils. We have to take a look at the breast. We have to examine the lower limbs for possible cases of deep venous thrombosis. We have to take a look at cyanosis and purpura in cases of septicemia. We check the breast, the chest, the throat, and we have to make sure that we are talking about puerperal sepsis. When examining the patient is usually has abdominal tenderness, rigidity. The uterine size is usually larger than normal in cases where there's retained products of conception. The uterus is usually subinvoluted. We examine the renal angles for urinary tract infection to exclude things like pyelonephritis, which can give us a similar clinical picture to puerperal sepsis. Now locally, when we do vaginal examination, we look at the type of discharge, its amount, its nature. Is it viscid? The smell. If we can also take a look at infected laceration in the vulva, in the perineum, in the vagina. We can also do a local examination under anesthesia to make sure that there is no lacerated cervix. We also take a look at the uterine size, and it's usually tender. When we do the vaginal examination, we check for pelvic swellings. Like we said, pelvic cellulitis might present with a mass in the pelvis, which can actually be to the right or to the left, or the uterus can push it to either one of the sides. Things like peritoneal spread. If we have a pelvic abscess, it will usually be in the Douglas pouch, so that can be palpated as well, and it is very painful. Now, Now, while investigating a case of puerperal sepsis, we take swabs from all the discharge, which is in the vagina and the cervix. We do both aerobic and anaerobic cultures and the antibiotic sensitivity, so that we can give antibiotic that can actually help us defeat the invading organism. We do a urine culture. We're using a catheter to withdraw the specimen to make sure that it is not contaminated by the vaginal discharge, and so that we can also rule out urinary tract infection that can give us a similar clinical picture. We do a complete blood picture. We have to take a look, see the total leukocytic count. We do a blood culture at the height of the fever in cases of septicemia. A Doppler ultrasound can be used to exclude deep venous thrombosis and to take a look at femoral and inferior vena cava obstructions and thrombosis. Chest X-ray is also very helpful to exclude pneumonia and other chest-related infections. Now, preventing puerperal sepsis. Now, that's a very important thing that during pregnancy that we have to treat any condition that might predispose to this. So a patient complaining of recurrent vaginal infection and urinary tract infection, we have to give the patient appropriate treatment. We improve the general condition of the patient, especially patients with anemia and diabetes. We can treat any septic focus. If the patient has dental caries, if the patient is complaining of tonsillitis, anything that might give rise to an organism in the body that might later on infect the pelvis and the genital tract, of course. Now, during labor, we use complete aseptic measures. We clean the vulva and the vagina. We avoid, of course, unnecessary repeated vaginal examinations as to not introduce organism inside the genital tract. We give antibiotics in cases where there was a history of prolonged labor or a history of premature rupture of membranes. We have to properly manage genital tract lacerations. You have to suture them, and you have to keep aseptic precautions and measures all the time. We also have to avoid retaining pieces of the placenta and the membranes inside. So when you deliver your patient, you have to take a look at the placenta and make sure that the membranes and the placental cotyledons are all complete before dismissing the patient from the delivery room. Now, maintaining aseptic measures during puerperium is very important, as proper good hygienic measures are always important to prevent puerperal sepsis. We have to teach the puerperal mothers how to go to the toilet, how to not contaminate their episiotomy site with stool, as sometimes this might actually lead to puerperal sepsis. Now, if you have people coming to visit the mothers after they had a baby, or even if your personnel in the hospital are infected, you have to tell them not to visit the puerperal wards or puerperal wards, as to not propagate or increase the incidence of infection. You have to tell the mothers after labor to sit in a semi-sitting position so that they can promote the drainage of local discharge from the genital tract, so that it does not accumulate and does not predispose to infection. If you have a case that you suspect might have puerperal sepsis, you must isolate that case, as the infection might spread and cause a nosocomial type of infection, and that may propagate in the puerperal ward and may cause puerperal sepsis and hospital-acquired infection. You can always also encourage puerperal mothers to have their respiratory and pelvic floor exercises to decrease the incidence of puerperal sepsis. Now, treating a patient with puerperal sepsis, you have to isolate that patient, as that patient might act as a septic focus, and she will be predisposing a type of nosocomial infection, as we had discussed before. We tell them to sit in a Fowler position, which is semi-sitting position with flexed knees. The diet is usually nutritive, light. We give them vitamins, iron, and plenty of fluids. There's also frequent measuring of the vital signs, so that we can predict if the patients go into deteriorate or might be heading towards things like generalized peritonitis or septic shock. We give them analgesics and antipyretics and assure them good rest and sleep. We give them a combination of antibiotics, which is the result of the culture and sensitivity from the swabs that we have obtained. Cephalosporins are usually good for gram-positive organisms, gentamicin for gram-negative organisms, and of course metronidazole and clindamycin for anaerobic infections. So after giving the patients triple attack antibiotics, we tell them to promote the drainage of discharge. So we tell them to stay in the Fowler's position. We give them ergometrine, which helps the uterus's ability to expel retained products or membranes. And if that fails, you actually have to do a DNC or some sort of a surgical evacuation of the retained products of infection, but it's done under anesthesia and a heavy antibiotic coverage, as the uterus is usually very soft, and manipulations in the uterus at that time might actually cause uterine perforation, which can lead to bleeding and excessive bleeding that might lead to laparotomy or even hysterectomy sometimes. Now, if you have an infected wound in the perineum or the vulva, the sutures have to be removed so that you can let the accumulated discharge to be drained. Otherwise, the patient will always have a septic focus and will not improve no matter what you do. So if a pelvic abscess is also formed, drainage must be done through posterior colpotomy. So pelvic abscess forms in the peritoneal cavity in the Douglas pouch, and it's accessed through the upper posterior fornix, where it's opened using a surgical incision and then drained. Treating complications of puerperal sepsis. Now we have something like septic thrombophlebitis and DVT. Now we give the patient antibiotics, anticoagulants for the DVT, and we tell the patient not to mobilize the limb until the temperature has fallen, so that we prevent emboli from reaching the lung and causing pulmonary embolism. Now, treating generalized peritonitis, we tell the patient that they cannot orally feed. We give them IV antibiotics. We decompress the GIT using a Ryle tube, and we give them massive antibiotics, as the next stage is usually septic shock, which is treated in the intensive care unit. Thank you very much.